Hi everyone, my name is Kiran Rana, and today our topic for NAC OSCE's approach to vaginal discharge. Before we get into the discussion, a brief disclaimer that this video is for educational purposes only and is not meant in any way to replace professional advice. And if you have a medical problem, please seek care from your healthcare provider. Now, what is vaginal discharge? Vaginal discharge can be normal and abnormal, and it refers to fluid or mucus that comes from the vagina. It is one of the common presentation that we see in family practice clinics, and it's usually seen in premenopausal women because in postmenopausal women, they lack estrogen, and therefore the discharge is minimal usually. It is also normal if the patient doesn't have any bothersome features. For example, if there is no itching or burning, then the discharge is going to be normal most likely. They can be mild odor and mild irritation of the vulva, and the normal discharge usually contains skin cells, bacteria, mucus, and fluid produced by the vagina and cervix. And the function of this fluid is to lubricate the vagina and protect against vaginal and urinary tract infections. The amount of normal discharge is usually up to a teaspoonful. It can be white or colorless. It doesn't usually have an odor. It's usually thick and mucus-like. But however, these features can vary from person to person, and they also depend on the phase of the menstrual cycle. The normal discharge usually increases during pregnancy, before ovulation itself, before periods, and if the patient is using certain forms of contraception, for example, oral contraceptive pill or patch, and vaginal ring. There is minimal discharge in postmenopausal women, and we've already discussed that. However, even if the discharge is normal but the patient is concerned, then it's a good idea to go to your family physician and get it checked, even if just means that the patient is going to be reassured. For abnormal vaginal discharge, there is itching of the vulva, vaginal opening, and labia. There may also be redness, burning, soreness, or swelling of the vulvar skin. If the discharge is foamy or greenish yellow, that's very characteristic of trichomonas. And if the discharge is white, that's mostly seen in case of candidiasis. Odor may be there, or it may be absent, but the bad odor is most common in case of bacterial vaginosis, and it has a strong fishy smell. If there is any blood in the vaginal discharge, then that should be worked up appropriately, especially in postmenopausal women who are more likely to have cancer and may need testing, for example, endometrial biopsy and other tests. There may be dysuria or dyspareunia, and the patient may also have abdominal or pelvic pain. Now, what are the causes and risk factors for abnormal vaginal discharge? Mostly it's the infections, and the infections could be yeast infection or bacterial. It can also be trichomonas or sexually transmitted infection. The discharge may also occur as a result of reaction to foreign body. For example, in women who use tampon and they forget to take it out, they may develop abnormal discharge. In case of use of condoms, and certain chemicals, for example, those used in the spermicide and soap, can also lead to abdominal vaginal discharge. It's most commonly seen in women who use frequent vaginal douches and those who wear panty liners on a daily basis. Certain female hygiene products, for example, sprays and powders or rinses, have those chemicals as well. And in case of prolonged bubble bath and scented bath products which contain the chemicals and can lead to foreign body reaction, that can end up in abnormal vaginal discharge. Tight and restricted clothing have also been associated with abnormal discharge. To diagnosis, history is very, very important, especially in case of NAC OSCE, and it's possible to make your diagnosis based on the history. Everyone has their own technique, but for me, I like to use some mnemonic. So in history of presenting complaint, OCD is pretty much a general mnemonic for me for any complaint. O stands for onset, course, and D for duration. And then for vaginal discharge, there's another mnemonic that is popular. We call it COCA-B. And C stands for color, O for odor, consistency you have to ask. You have to also ask about the amount of discharge and if there is any blood. Based on that, you would have certain differentials for the discharge. And then you would proceed to the next component of the history, which are past medical history. So you can ask them about the drugs and allergies. You can ask them about the comorbid conditions, diabetes, high blood pressure. After you're done with past medical history, then it's important to ask about the menstrual history and take a brief gynecological history. Ask them about their pap test, if they have any pathology, pelvic pathology, or questions related to their general hygiene. Another important question to ask is about the IUD use, because if they are having a discharge with IUD and they're sexually active, then they're likely to have pelvic inflammatory disease, and we need to rule that out. Brief obstetric history can be asked in this case, and sexual history is very, very important. So you have to take a detailed sexual history and ask them about the number of partners, similar symptoms in the partner. And once done with that, you can ask about the family history, social history, and review of system. A few questions about those would suffice. Then after the history, you would do the physical examination of the external genitalia as well as the abdominal examination. And then you would proceed to the first speculum examination. And during the examination, you'll take a sample from the vagina and a cervical swab for Neisseria and gonorrhea as well. You can also take a bit of vaginal discharge, put that on the slide, and view that under microscope. That is called the wet test. And another test that we call the bifamine test, where a drop of ammonia is placed on the vaginal discharge, and then we need to observe the smell. We need to smell for if there is any offensive odor, and if there is, then the test is said to be positive. So this is a very important slide, and you can get something like that in the examination. This slide has symptoms and sign as well. Of course, you won't get that in the examination because you have to take the history and find those signs and symptoms for yourself. But the examiner may give you vaginal pH on the paper that they hand over to you. They'll give you the wet mount findings and the findings of the bifamine test. So if on your history you have elicited pruritus, if there is also mild odor along with dyspareunia, and on your examination you see vulvar erythema, then you're thinking more on the lines of yeast infection. And on the paper, if the vaginal pH is between 4 to 4.5 and you see pseudo-hyphae on your wet mount test and a negative amine test, then you can safely diagnose Candida. In case of gray discharge with strong odor, a pH of more than 4.5, and then you may be able to see the discharge when you do the external genitalia examination, and you may find clue cells. Clue cells are basically vaginal epithelial cells which are surrounded by an overgrowth of Gardnerella vaginalis. Gardnerella vaginalis is a bacteria that is normally found inside the vagina. However, if there is a change in the pH, if there is any use of antibiotics or intercourse that can disturb the chemical balance inside the vagina, that can lead to overgrowth of the bacteria, and you may find clue cells on the wet mount. Amine test may be positive, and by that I mean if when you put the drop of ammonia on the slide, there's going to be a fishy, very strong fishy smell, and we call that a positive test, and that would point towards a diagnosis of bacteriovaginosis. In case of trichomonas, the discharge is going to be greenish yellow or purulent discharge. The patient is going to have dyspareunia or pain on intercourse. pH is going to be 4 to 6, and you'll see erythema around both the vulva and vagina. You may find some WBCs, and then you should be able to see trichomonas, which is a flagellated protozoa, and you can view that on the wet mount test or on the slide that you've made. And the bifamine test may give variable results. You may find some strong odor, or it may be not strong enough for the test to be positive. Now, this is a cell where you can see the normal vaginal epithelial cell as well as the one which is surrounded by Gardnerella vaginalis. And you can see, like in healthy vagina, there are only few bacteria, but in case of overgrowth, the vaginal epithelial cell is surrounded by many bacteria, and that's when we call it a clue cell. Next wet mount is of a yeast or candida. You can see the hyphae as well as the pseudo hyphae. And if you have that picture, that means the patient is having vaginal candida. This one is a picture of the trichomonas, and you can see the flagella as well as the protozoa. How do we treat this condition? So in case of bacterial vaginosis, the recommended treatment is metronidazole 400 milligram twice a day for 7 days. Alternatively, you can also use clindamycin. In case of trichomonas vaginalis, metronidazole is used again in a single dose of 2 gram. And it's also important to remember that we have to treat the partner as well, because it's one of the sexually transmitted infections. For candidiasis, either cream or the pill can be used. Cream comes in 2 strengths. One is 1% and the other is 2%. So for the 1%, you're going to have them apply it once a day for 7 to 14 days. For 2%, they have to apply it once a day for 3 days. And if they prefer, and many patients do, because of the comfort, based on their comfort, it's more convenient to take only a single dose of fluconazole at a dose of 150 milligram, and that should be enough to treat candida. Now, this is a treatment for the gonorrhea and chlamydia, and the recommendations do keep changing from time to time. So in the past, if the patient were diagnosed with any of them, then they would be treated for both of them at the same time. And the treatment was usually ceftriaxone 250 milligram intramuscularly, 1 dose only, along with azithromycin 1 gram once only. However, that has changed over time. For example, in 2015, you can see if the patient was diagnosed with uncomplicated gonorrhea, and by uncomplicated, I mean gonorrhea that is limited to the genital tract and hasn't spread, hasn't gone to the blood, and doesn't involve other parts of the body, then it's treated with ceftriaxone along with azithromycin. But if the patient was diagnosed with chlamydia, they only needed azithromycin. Now here, in June 2021, the guidelines changed, and if the patient was diagnosed with gonorrhea, we would only treat them with ceftriaxone 500 milligram intramuscularly once. And that dose has almost doubled since the past because of the resistance pattern. And if the patient's diagnosed with chlamydia, they are being treated with doxycycline 100 milligram twice a day for 7 days, because that has been found to be more effective than azithromycin in a dose of 1 gram. So one likely reason why we are treating them individually is because when we take the swab, we test for both gonorrhea and chlamydia, and the result comes back and lets us know whether gonorrhea is positive and chlamydia is positive as well, or whether one of them is positive only. So I think that's the reason why the guidelines have changed, and they've been studying the efficacy of the treatment regimes that were being used in the past. So it's good to keep an eye on the guideline, but for the sake of NAC OSCE, I would still say that it's better to tell the examiners that you would like to treat both the infections at the same time, unless they give you the results where you see that the chlamydia is negative and only one of them is positive. And also, it's important to mention that the partner needs to be treated as well, and they need to refrain from any sexual activity until the treatment is complete. And just a few cases to practice, and which will make it easier for us to understand what we have learned in the last few minutes. So the first case is of a 25-year-old female who presents to the GP's clinic with foaming greenish yellow discharge, and she has mild itching around the vulva for the last 3 days. She's sexually active and does not drink alcohol. So what is the diagnosis and treatment here? So it's important to remember that first we have to look at the features of the discharge itself. It's foamy. That is a very strong clue of trichomonas, along with greenish yellow discharge. So greenish yellow is seen in trichomonas itself, whereas in bacterial vaginosis, it's mostly gray. There is mild itching, but that can vary. There can be moderate itching as well, moderate to severe, but that's more non-specific. And then sexually active is another clue, and it's very important. So in someone who's not sexually active, they're less likely to have trichomonas. And then she doesn't drink alcohol. That's another piece of valuable information. So when you are taking a history, you still have to make sure that you're thorough and ask all these questions after taking a focused history about the vaginal discharge. Now, so based on these symptoms, the most likely diagnosis is going to be trichomonas. And how are we going to treat it? We're going to use metronidazole in a single dose of 2 grams, and it's safe to use in this patient because she does not drink alcohol. If she was drinking alcohol, that would cause some unpleasant side effects, for example, nausea, vomiting. So in that case, we had to tell her to stop the drinking for the treatment duration. Another important piece of information is to tell the patient that the partner needs to be treated as well with the same dose of the medication. Our next case is of a 35-year-old female who came to the primary practice with thick white discharge for last 2 days after using antibiotic for sore throat. Just finished the course of the antibiotic. And she had a lot of itching and redness around vulva. And then she doesn't have any fever, and there is no history of diabetes or hypertension that you elicited in the past medical history. And now, what is going to be your diagnosis in this case, and how are you going to treat it? So, thick white discharge, again, is a very important clue. White, the color, is very typical. It may be white in other conditions as well, but you have to combine these signs and symptoms along with the rest of the history to reach a final diagnosis. So she's having white discharge with a lot of itching, and there's also erythema. When you combine these features, it points toward candidiasis. And what supports that further is the use of antibiotic. So most likely she's suffering from candidiasis. So you have to do the wet mount, and if you see pseudohyphae, that would confirm the diagnosis. But in GP's clinic, we can, I've seen them treating the patient based on signs and symptoms. And so the diagnosis of vaginal candidiasis, the treatment is going to be fluconazole, 150 milligram in a single dose. And you would ask the patient to come back to us if there is no improvement. And that's usually what most of the physicians have been doing, because doing the wet mount during a busy practice can be a bit difficult and time consuming. So, and we have to do a follow up for every patient in any way. Like if there's no improvement in symptoms, then it makes sense to let them know so they can seek care and come back to us, or go to the emergency depending upon the condition. So that's all I have about the vaginal discharge. You're most welcome to ask me any questions related to this presentation or for vaginal discharge. And I would advise to practice with your study partner to get better at it. And it's one of the common topics for the exam.